We're now going to be moving on to learn about those groceries. We have the Assistant Director of the Nutritional Services here at Mayo Clinic, an Assistant Professor in the College of Medicine at Mayo Clinic, and also a new personal friend, Dr. Ron Stone. I think I promoted you to doctor. I'm sorry.
Yeah, there you go. Give me a little bit, few other extra years.
How's that?
I'm gonna reload mine up. Extra slide.
Okay. Okay.
All right. There we go. I was going to say AV, help me out here. All right. Thank you guys for having me today. I appreciate Dr. Tatum and Danielle inviting the nutrition folks to this. We always are happy to present and to be involved. So I'm going to tell you a little bit about diet and seizures today. I'd like to know, first of all, how many of you have been prescribed or have self-prescribed a diet for seizure disorder? All right, a couple. All right, very good. So there's a lot here for you all to learn then today, and that's great. Really want to share some things that we know. First of all, when we usually give these scientific talks, for HIPAA reasons and other reasons, we do disclosures. So I have no disclosures from a vendor standpoint here to make, but I will disclose a few things here for you. First of all, not everything out on the food tray line there was dietitian approved. So, though we do appreciate all those that gave us the food today, could you tell which ones might have been dietitian approved? All of the fruit and vegetables certainly are not only dietitian approved for healthy eating, but they're also ketogenic in nature. And second of all, as I've been sitting here all morning, I've noticed that there are a lot of young people in the room. And that always equals a lot of texting and cell phone and Twitter and that sort of thing. So I do want to tell you all that I have an EMP device embedded into the slides so that any unauthorized use of cell phones during the presentation could cause that to be permanently disabled. So listen up, guys. All right, so today we're going to talk about ketogenic diets. We're going to explore the history of the ketogenic diet. We're going to define what that is in detail. We're going to discuss the efficacy or how effective this diet is in controlling seizures. And then we're going to talk a little bit about a couple of alternatives that have been researched more recently that are a little bit more easy to operate with families and folks that are on these diets. That's use of medium-chain triglycerides, which really is a manufactured fat from coconut oil. We have the modified Atkins diet, and also the low glycemic index therapy. And so each of these diets are starting to be researched and used more in both child and adult seizure disorders. So I'm proud to say that this is the Plummer building here. Practice with this thing a little bit. Didn't seem to work. The Plummer building's in Rochester. So Mayo Clinic in 1921, Dr. R.M. Wilder was the first on record to publish and talk about the ketogenic diet. And basically, this is a high-fat, low-protein, low-carbohydrate diet that mimics starvation, which had been previously shown that to put someone on a fast 48 hours, 72 hours could help with seizure reduction. The benefit of this is that you could actually mimic starvation and still eat and still have a similar result. So that's the first we know of the ketogenic diet. So what is the ketogenic diet? Have most of you heard about the ketogenic diet? And so you have some knowledge about that, about what that is. Essentially, it's a diet that produces ketones or ketosis. As the bottom point says here, those who are using ketones as primary source of energy are said to be in ketosis. And what happens is, in the absence of carbohydrate, which is our primary energy source, when we start burning fats as energy, the byproduct is ketones. And this is very, very important as humans evolved over time, in that when we, as an early developing being, would go long periods of time between food sources. You know, we might, as we were hunters and gatherers, we might come across a harvest and eat, or come across a group of animals and be able to feast and eat, and then we'd go long periods of time as we moved on in a semi-starvation mode in order to find our next meal. Well, the body developed a way to utilize our fat sources to burn energy and to create these ketones, which help us with energy during periods of starvation. So they are a great source of energy. They occur in the absence of carbohydrates, and they are a key energy source for the mind or the brain, which is why a lot of the research has been going into how do ketones impact how our brain functions, specifically as maybe a protective mechanism. So why does it work? Well, Dr. Tatum stopped me in the hallway earlier, and he says, why does it work? And I went on and on and on. I said, well, Dr. Tatum, you know, you got this mechanism and this and this and this. And he said, I think I missed the answer in there. I'd like it in one line. So I can show you a little bit about what I was telling Dr. Tatum here. And I'm not going to actually go into that. Unless there's a biochemist in here that wants to talk to me about this afterward, we could do that. But the real action of why it works, the real answer is we're not really sure. We don't know, and so this is the idiopathic answer. The dietitian's an idiot. We don't really know. So, however, data does suggest that following this diet, and this is sort of a quote, it activates this genetic programming that counters the neuron dysfunctions in the brain that result in seizures. So we sort of know what it does, but we're not sure why. And we do know that this diet, as you saw earlier, used as early as 1921, has about 90 years of research involved. But yet the complete mechanism is poorly understood. So we're going to go into some three key components, because as we look at why the ketogenic diet works, which has all three of these, perhaps we can start understanding a little bit more about why some of the more liberalized diets work if we look at all three groups here. I really wish my pointer worked, so I'll just put it down since it doesn't. Ketone bodies, we do know that they produce anticonvulsant properties, but sustained ketosis is required, which means that if you bounce out of ketosis, you have too much carbohydrate in your diet, you will go out of ketosis, and then you won't have enough ketone bodies there to work. We also know that glucose restriction works and calorie restriction, and to some regard then, this is how our body takes in, utilizes glucose and turns that into energy. We call that glucose homeostasis. And we know that the restriction in the glucose itself limits the neuron's ability to reach the high levels of activity that are required in seizures. So perhaps it's ketosis, but perhaps it's also this impact of glucose restriction. And then these ketonic diets are very high in fat, up to 90% in fat. And this higher level of polyunsaturated fatty acids that's found in these diets are said to perhaps block seizure by reducing the neuron hyperexcitability. So there's the three main things that earlier really convoluted slide showed, which may be reasons why it works. So here's some consensus. The reason why diet's not primary therapy was talked about in several of the other presenters today is that 50% will respond to one medication. You'll have a little bit better response to two medications, and then there's some other treatments like the vagal nerve stimulation and the surgery, and so a good number of these patients will respond, about 66%, without having to develop a diet. However, 20 to 30% have refractory epilepsies, and these patients should be considered for a ketogenic diet. It is medicinal in its function, and it does work for a good number of people. The other thing is a lot of folks, as we see more adult seizure disorders, have felt like ketogenic diet or diet therapies were only for children, and in reality we know that they can work across the lifespan regardless of seizure type or etiology, which is cause, regardless of age, and it appears to provide some seizure reduction for about 90% of patients, and for about 1/3 they may be seizure-free. So that's pretty good. Who are good candidates? Again, we do not use this as primary therapy. We want patients to have tried other therapies, but when you're not responding to meds, you have intractable seizures and so forth, this could be a last resort that you would go to. There are some exclusionary criteria. There's some inborn genetic and metabolic deficiencies that we would have to rule out. If you already have significant kidney problems with kidney stones and that sort of thing, you may not be a good candidate. Older patients who want to start this that have advanced heart disease, obviously because of the high level of fats, might not be a candidate, and so forth. So these diets do require medical supervision, and we call this a medically supervised diet. Classic ketogenic diet basically requires you to be in ketosis, and that's you can buy the little ketone testing kits at your pharmacy and so forth, and that will basically test your urine pH to tell if you're in ketosis. 80 to 90% of the calories are from fat, so it is a very, very high fat diet. And what we try to do then is the other remaining 10 or 20% are all coming from your other two macronutrients, proteins and carbs. And we'll tend to start you on a ratio of about 2 to 1, so 50% carb and 50% protein, 50% fat, 50% protein and carb, and we'll titrate that up over time until your graph looks like predominantly fat with a very small percent. And I'll show you a nice graph here a little bit that shows you that. It does require close monitoring of glucose, electrolytes, and hydration early on, and so most centers, if not all, require hospitalization to start you on this diet so that we can monitor until you're good. There are some centers that have started that transition you to the outpatient very quickly with a much more gradual approach, and they have shown that you don't have to have this 3-day massive start to the diet to necessarily be successful. You can do a little bit more of a gradual approach, and that's gaining some traction. Well, how effective is it? In this particular study, those that were initiated on the diet at 6 months, 66% were still on the diet, so fairly good. The rest of those that dropped out, we call that attrition, and they drop out for a number of reasons. Lack of tolerance to the diet, whether it be GI upset or so forth, lack of resources to continue the diet therapy with a dietitian and so forth. But 66% are still on the diet, 41% had 90% seizure control, another 35%, greater than half, 50% seizure control, and a small drop-off of about a fourth that had less than 50%, which maybe we consider a failure medically. But however, if you're that individual that's having the seizures, maybe that is even enough to show some benefit. And then those are the numbers at 12%, so you do have pretty good response to this type of diet. So some discussion about the diet. The neurologists, they believe that it takes about 2 weeks to respond. It's a gradual increase to get to ketosis, and it does take a little while to reset those genetic factors that and those biochemical pathways that make it work. So like a lot of medications, they take several weeks to work. The diet's very similar. But we do say it should be, if you're going to try it for at least 3 months, because just because you're not an early responder doesn't mean you're not going to respond. Without response in 3 months, we try something else. We think maybe the diet isn't going to work. We do believe that the diet is both works well for glucose control because of the ketones and the polyunsaturated fatty acids, but also calorie control tends to be important also, and if you can, even if you stay in ketosis, exceed too many calories, you can have issues. So calorie restriction tends to play a role also. And then this one's a big one, is that, everybody, all of us have tried diets before, whether it be for weight loss or any other ailment, primarily weight loss, and we all know that we cheat, right? And so the problem with this diet is that if you sneak just a little bit of carb, that can cause what's called a breakthrough seizure and really set the whole therapy back. So it's important that you follow it very strictly. Some nutritional shortcomings. We do recognize that this diet is deficient in some vitamins, minerals, and nutrients. When you take fruits and grains and a lot of those foods out of your diet early on, you could have some vitamin mineral deficiencies, so it does require some supplementation. We recommend universally a multivitamin with minerals and calcium and vitamin D. You can, to treat some of the side effects like constipation and that sort of thing, you can have some laxatives. A certain percent of patients will develop carnitine deficiency, so we have carnitine that we would check those levels. If you are deficient, we would give you carnitine. The use of MCT oil we'll talk about, and then oral citrates to help prevent kidney stones. Side effects include, and you hear this at the end of every commercial, you usually hear it, like side effects include constipation, vomiting, diarrhea, abdominal pain, reflux. So those things do happen. Metabolic, you could have some low calcium, magnesium, carnitine levels. About 11% increase in cholesterol levels was seen in some of these studies. Slowed growth, especially in younger children, could occur, and decreased amino acids and protein level stores. So again, it is medically supervised because we need to be checking these things along the way. Patient responsibility. Well, I've had a couple of calls just this week on these various diets, and one thing is that you do establish care primarily with a neurologist who is helping to manage your seizures with the medication, so that they know you're going to try one of these diets, and so that they can help do the lab work and so forth. It helps to have a dietitian. The meal planning can become difficult. There are some online resources which I'll share to you at the end, but it's very helpful to have someone manipulate the numbers, especially the ketogenic diet, which is these 4-to-1, 3-to-1, 2-to-1 ratios can be a little bit difficult. It helps sometimes if you have a social worker or a behavioral psychologist like Dr. Cox, that can sort of help with the family dynamics and that sort of thing and how all this is going to work. We do bold in red that not to try it on your own, because some of the fluctuations in your hydration, your electrolyte levels, and that sort of thing could be catastrophic without being managed. Strict adherence to diet and follow-up is certainly key. Now, MCT oil, we use this a lot in our hospital here to supplement as a fat. We use it a lot as well in patients with GI abnormalities. MCT oil is a fat that's absorbed. It's water soluble, so most of your fats are not. If you want to have an example of that, take your oil and vinegar dressing in the refrigerator and let it sit, and you'll see all of it separate. Everything that separates is the fat, because the fat's not water soluble. So MCT oil it has a lot of good uses. It's made from coconut oil. And it yields more ketone per calorie than regular fats. And so the beauty of this is the thought that patients tend to not like being on 80 to 90% of their calories from fat. And so if you start adding some of those calories from fat as MCT oil, you can do about half and half. You can do about 30% from MCT, 30% from dietary fat, and that allow you to get more of only 60% of your energy from fat instead of 80%. And what does that do? That opens up your or your child's horizons to some more foods that are in the food chain there. It's not abundant in food, so it has to be supplemented, and it's usually, because it's in liquid form, it's usually added to foods and that sort of thing. And some patients do have tolerable issues, but not all, and you'll recognize those fairly rapidly. So the MAD diet, it's really sort of, like all of these diets basically are taking your macronutrients and, acting like a chemist and trying to figure out what's the best ratio of all these things. But really, this is sort of an oxymoron in that most people are not mad when they go on this diet. They're more happy, especially if they've been on a ketogenic diet, because it really liberalizes some of their food options. Now, at first, this stimulates the first induction phase of Atkins, and that's why it's called the modified Atkins diet. And it restricts carbohydrates to 10 grams initially for a child or 15 for adult. And then month by month by month, we try to add a little bit more of the carbohydrate into the diet until we reach about 30 grams and that we have seizure control. And so you do get a little bit more carbohydrate in the diet, and we'll compare all the diets together toward the end. This diet can be done as an outpatient. It's not as, the side effects of the diet aren't as great. We don't expect a lot of the electrolyte abnormalities to be occurring. The other thing is that the ketogenic diet is very weight and specific controlled. You're measuring everything, measuring every gram. And for this diet, just like the Atkins diet, as long as you're focusing on the protein and the fat foods and minimizing certain choices of carbohydrate, then you don't have to measure and calculate. And people really like that a lot because your kitchen becomes less laboratory and more kitchen again. Fluids aren't restricted, protein is not restricted, so you can eat ad lib from the protein and high-fat foods, and that is why the proposed better compliance is there. And the more, regardless of how effective a diet is, if the patient doesn't follow it, then it's not going to be effective. So compliance is always an issue with patients, and we really try to help those get that. Now, the other thing is fiber, since fiber is not really readily absorbed and metabolized as a carbohydrate, if you eat higher fiber foods, you're allowed to have those and subtract that carb from your total carb. So as you were out there today and picking some of the veggies, the broccoli, the cauliflower, those sort of things that are so high in fiber, you don't have to count those as your carbs. So a lot of the vegetables are sort of free foods, and you can really fill up on those, and you get a lot of the phytochemicals and healthy protective things from the plant-based foods, so that's really good. Numerous studies on this the past 7 years. Overall response is about 50 to 60% reduction in seizures, slightly less than a ketogenic diet, but still pretty promising. It's dependent on the patients, and again, that most of us will know within the first 2 weeks if it's going to work. You'll start to see some significant reductions. So here's the comparison. The average American diet on your far right, my left, is about half carbohydrate in the yellow. If you go all the way over here to your far left, you have the carbohydrate 2% on a ketogenic diet and up to 6% or so on the Atkins diet, but look how much extra protein you get. So the blue, which is the fat, really starts to shrink, and it makes the diet much more feasible, much more tolerable. Now, a really more new therapy, which I think is very, very promising because, again, this diet starts to add some more of the carbohydrate back in. This mechanism really looks at the third piece, the glycemic impact, or the glycemic or carbohydrate metabolism impact on why the ketogenic diet even worked. This was, again, on that one slide, the second one, the glucose homeostasis, is that if we choose certain foods that have a low glycemic index and carbohydrates, the body doesn't react to them the same, and therefore they can be protective. And what you have here is a slide. The orange is high glycemic foods, and when you take these high glycemic foods in, you have this jump in blood sugar that causes a response, metabolic response to counter that, and there's a lot of different pathways involved, including insulin and glucagon and a number of other things, and that may be a triggering event then to help to talk about seizures. And these low glycemic foods, they stay under that curve. They have much more gradual, long response and not that spike, and therefore maybe these foods can be incorporated and not hit that response. And it's very interesting how this science works, because if you remember my very first slide is talked about they put folks on starvation to help with seizure control, and then we decided, hey, if you gave certain foods that mimic that starvation, like fats, you can get control. Well, now this is allowing a certain type of glucose or carbohydrate that would also mimic or change the way our body responds to food. So this is pretty exciting. Initial study done, just 2 adolescent boys with 90% reduction that could not continue, and both of those had very good results, and there's been a few other larger studies also. Everybody familiar with the glycemic index? There's several books out there. I think the people that made it popular were Sugar Busters, but that book's a little faddish in terms of their glycemic index is not always correct. There is a national index that's been put out on the glycemic index that you can find on USDA website, and it's about 60 or 80 pages now. So there is some science behind it. In this diet, you're allowed 40 to 60 grams of carb per day, so a lot better. We went from about 10 grams to 30 grams to now up to 60 grams. All of these diets are low carbohydrate diets. Let's keep that in mind, but they are still allowing you to have a little bit more. Interesting enough with this diet is many of these patients have seizure reduction without ketosis. And that is very interesting, because we always thought that very first bullet, that the ketone bodies were the key to the diet, and now we're starting to see some success without the ketosis, which is quite interesting. The way this works is we divide the carbohydrate evenly over the day so that you don't eat all of it once. The more evenly divided it is, the less of a spike you have, and the more leveling of your blood sugar throughout the day it is. But however, we do count fiber and sugar alcohols in this. So you're getting, even though you're getting a little bit more carbohydrate, the fibers and those sort of things are added in. Our goal is for fat is 60% of calories, and so you'll still have 40% to use protein and carbohydrates in there. 66% of patients in what we have now showed at least a 50% decrease. 1/3 of the 66% are seizure-free. And so this shows that and they actually showed that the lower the patient's blood glucose was and the lower it was over time throughout the day, the better patients responded. So this really starting to take us into the whole idea about the very specific glucose control or glucose homeostasis and what impact that has on seizure control. And as with anything, we had some attrition rate, and they cited restrictive in nature, and to quit even if they had benefit, and that someone who can't follow this diet certainly will probably not be very compliant with the modified Atkins and certainly not ketogenic diet. So here's the all diet comparison. Fat content of the ketogenic diet up to 90%, low glycemic index in the modified Atkins about 60%, so that allows more carbohydrate. The low glycemic index makes up the difference in calories mainly from low GI carbohydrates, whereas the modified Atkins makes up the difference in calories through protein. So those are the two differences there. Both the ketogenic diet and the low glycemic index diet discuss using measuring tools. The modified Atkins is more of a free-for-all, eat protein, eat fat, just stay away from the carbs. And the calories are controlled in both the ketogenic and low glycemic index. They're not controlled in the modified Atkins, but plenty of research in weight loss patients have shown that patients who are on an Atkins-type diet tend to reduce their calories anywhere from 200 to 400. And that's because when you start adding fat and protein, which is very full, very filling, protein in particular, you're not able to make up your calories that you lost. So that's why a lot of those diets work for weight loss as well. And your ketone testing is recommended in the ketogenic and the MAD diet, but not so much in the low glycemic index diet. So those are the three main diets. And these are basically some of the numbers that I showed. So to date, the low glycemic index, we don't have an evidence-based, multi-centered, well-done trial that talks about seizure control. We have a few, and one in particular that was properly had enough people in it to be statistically significant, where they had greater than 50% control. And so those are the numbers, and you can see that of these, the more strict the diet is, probably the better the results have been. Now, rather than what we recommend or what we're looking at in therapy here is that if a patient has uncontrollable seizures, should we jump right to the ketogenic diet, or should we start with the most flexible diet and then work our way down? If a patient responds well to low glycemic index, maybe that's their lifelong therapy. If not, maybe we go down to the modified Atkins and then all the way to the ketogenic diet, because certainly you wouldn't want to necessarily start with the most aggressive therapy if you could be treated with less. So that's some of the thoughts there. How do we help? Well, certainly your medical team is here to help identify proper candidates, the seizure type that the patient has, rule out any metabolic disorders that would make these diets harmful to you as a patient. We will evaluate complicating factors like history of kidney disease, kidney stones, that sort of thing. And the dietitian's paramount, not just because I am one, but we're paramount in helping with these, what we consider a diet prescription. In these disorders, diet works like a medicine, and just like your pharmacist would assist the physician with medications, we would assist them with a diet prescription. Supplements also, making sure that you're properly supplemented and that you have a good education on ketone and food logs. What do we provide in our educations? We talk about food logs and recording and making sure that the patient has some accountability and some knowledge about what's in the foods that they're eating. Once it seems hard at first, but once you've got down a good food log, we tend to be creatures of habit, and that we will eat, as everybody used to having like pizza night on Friday growing up, and we tend to eat the same things pretty consistently, and over time. And so usually in about 3 weeks, you'll have everything that you typically eat in that log. And once you've learned that and you know how much protein, carb, and fat is in it, you can commit it to memory and it becomes easy. We help with sample menus and some other things like that also. So I checked this patient's record to make sure his name was not on file. We wouldn't want Mr. PH to know, and he did disclose that we could show his picture. This is Dr. Tatum prescribing him a low-carb diet, and was seen in our office later and has lost 10 pounds already. So for our families, families are a big piece of this puzzle, all right? And not just the immediate family either, but the extended family, brothers and sisters, and then aunts and uncles, and you folks that are grandparents already also. Third bullet there, it's not okay that little Johnny's been good all week and he gets a treat. Because that treat can take him off of his diet and have significant impact with breakthrough seizures. So family compliance is a major piece of success, and everybody